Hi, everybody. Thanks for joining us again. I'm going to get started because I think we're going to have a good deal of questions at the end here. Just to let you know how we're going to go about this today. We're going to have a short presentation again, and then open it up to question and answer. We'll start with the questions that we were asked ahead of time, and then move on to questions that questions that you ask through the Q&A window here today. Briefly, I'm Richard Month. I'm the president of the PSA. On the panel today, we have Dr. Michael He, who's the chair of our ad hoc committee on COVID-19 response, Dr. Gordon Morwood, who's our vice president for professional affairs, Dr. Joe Galassi, who's our co-chair for of our committee for governmental affairs, Josh Atkins, who is a member of our executive committee, and joining us in a few minutes will be Jack Gucci, who is the Associate Chief Medical Officer for critical care for Penn Medicine and has been leading Penn's ICU response. Next slide, please. Brief disclaimer again, we're here for informational purposes. It's not medical or legal advice. We may be talking about things that are contrary to CDC guidance involving off-label use of medications or equipment. Also, we speak for ourselves on the panel. We're not speaking for our employers, our practices, the PSA, the ASA, or the Pennsylvania Medical Society. Next slide. So this was last week. We saw this slide last week. This was now 6 days ago. We had a total of 479 cases with 2 total deaths. And just to put this, and the disease was in 33 counties. Just to put this into perspective, next slide. These are the statistics as of midnight this morning, or 11:59 last night. 2,751 cases, so that's a 33% increase per day since last we spoke. There are now 34 total deaths, and the disease is in 56 counties out of the 67 in Pennsylvania. Of note, Philadelphia is now up to 709 positive cases with 5 deaths. That 709 cases is up about 40% per day since last we spoke. To put this, something to take home for everybody, about 53% of the positive tests have been in patients 49 years of age or younger, and hospitalizations, 25% have been in people younger than 49, and 52% have been in patients younger than 64. So we are expanding. I'm going to hand this off to Mike, and he's going to continue the presentation. Next slide.
Hi, thanks for joining us, everybody. My name is Michael He. I'm the chair of the ad hoc committee on COVID-19. So this slide, the first one you're going to see, is basically just a COVID-19 tracker made by Johns Hopkins University. It tracks real-time data on COVID-19 cases across the globe. You can also filter it down by country, filter it down by the states, and also by county. It'll give you a real-time estimate of confirmed, recovered, and the total deceased as well. Next slide, please. So in terms of ICU surge planning, that's where we're going to focus the majority of our discussion on here today. Based on data published by the American Hospital Association, there's roughly about 5,200 registered hospitals in the country. Only about 2,700 of them, however, are able to deliver ICU services. So if you take those 2,700 hospitals and look at how many beds they have about a little over 530,000 acute care beds, and these include just your regular floor beds and medical wing beds. Out of these 534,000, only about 96,500 are true ICU beds, and of those, only 68,500 are adult beds. The rest are your pediatric beds, your neonatal beds, things that don't really support COVID patients. Next slide. If you look at the per capita ICU beds, the United States actually leads the world with about 34.7 ICU beds per 100,000 inhabitants. However, we feel that that will still be woefully inadequate when it comes to the amount of patients that we will be seeing coming into the ICU. Next slide. When you take a look at the actual estimated hospitalization rates from the AHA, we estimate that out of the total population, roughly about 4.8 million people will actually get hospitalized for treatment of COVID-19. Majority of them will not need to be hospitalized. However, still 4.8 million people will eventually need some hospital care. Out of those 4.8 million patients, roughly 1.9 million patients will be ICU admissions, leading to about 960,000 of them that need some kind of ventilator support. Now, if you take a look at the estimated number of ventilators below that, we only have about 200,000 mechanical ventilating devices in the country. Now, 62,000 of these are your full-featured ICU ventilators that can do inverse ratio ventilation and all these other features. 98,000 are pretty much your old basic ventilators, including those in storage that they can take out and repurpose. Also included in this 200,000 number are all the anesthesia machines that we have as well. So 960,000 patients that need ventilator support, 200,000 mechanical ventilation devices. Certainly not enough to take care of them all at once. Hopefully, though, if they come in waves, it will be enough to actually sustain them for the time being. Next slide, please. There's also going to be a significant shortage of critical care staff. There's only an estimated about 20,000 intensivists in the country, along with 34,000 APPs. Their max capacity to care for patients would be roughly about 135,000 ventilated patients. So there's an urgent need to have more critical care personnel. So there's going to be a need for non-critical care staff to pretty much step up and help out in this disaster situation. These non-critical care staff really need to be stratified by how much critical care experience they have. Most anesthesiologists will have some critical care training, but a lot of surgical subspecialties may not, and a lot of hospitalists may not as well. However, they will need to be part of the equation as well, and training needs to start immediately to get these people at least familiar with the settings. Next slide, please. So the Society of Critical Care Medicine actually has made a tiered staffing strategy for the COVID-19 pandemic, with the intensivist being the overriding physician taking care of patients. These intensivists will subsequently supervise tier 2, which are the non-ICU physicians, and in that case, it would most likely be the anesthesiologists, since we don't necessarily practice in a critical care setting, but we do have critical care experience and critical care training, and we'll be working hand in hand with the ICU APPs under the consultation of a critical care physician. We, in turn, will be expected to then manage our nurse anesthetists, respiratory therapists, non-critical care APPs to help take care of patients. Those are the ones that most likely will have some type of ventilator training. Also in that tier 3 group will be non-critical care MDs as well, such as your hospitalists, followed by your ICU nurse and your non-ICU nurses. Next slide, please. This is just a breakdown of what we just discussed. As you can see, the non-critical care anesthesiologists are really in the tier 2, basically providing ventilator management, fluid management, pressor management, and direct consultation with an intensivist. And this is especially true when the surge hits the ORs and exceeds ICU capacity. Next slide, please. There also needs to be a tiered model for beds. Where are you going to put these patients? An example would be COVID-19 patients right now can be placed in an ICU if there's negative pressure rooms. But what happens when you surge past that? You may need to go to the next tier and start cohorting these patients in an isolated unit, and then subsequently overflow into a pre-procedure area or a PACU once the ICU is full, and then subsequently overflow into the OR. So all these things need to be thought of and need to be planned ahead of time. What happens when your OR is full? You have other staging areas for these patients, maybe a removable trailer or tents or anything like that. And then when you get to max capacity, what do? Can you start doubling these patients in rooms? These are all things that need to be taken into account. Next slide, please. So in terms of using anesthesia machines as ICU ventilators, because there's a lot of concerns about this, the Anesthesia Patient Safety Foundation has actually put out a guideline of how to accomplish this. And recently the FDA has just declared that anesthesia machines in a crisis may be used as ICU ventilators. Of course, these are just recommendations. Anesthesia machines were not meant to be used for long-term ICU ventilation and should only be done in dire situations and on a temporary basis until a dedicated ICU ventilator is available. However, the Anesthesia Patient Safety Foundation does put out some recommendations as well as a quick reference guide, which is what you're seeing now, in terms of how to set the ventilator for these patients, when to check the alarms, how often to change the filters, and then how often you have to perform a self-test on these ventilators, which means that you would have to take the patient off the machine and do some kind of manual ventilation while these self-tests are performed. Because if not, these machines will actually start shutting themselves down step by step. Next slide, please. For those who need more resources for critical care medicine, the Society of Critical Care also puts out a COVID-19 resource guide for the non-critical care physician. I encourage everybody to try to access these resources. It gives some good guidance and algorithms on how to take care of critical care patients and what to do for ARDS settings. Next slide. There are a lot of other things that we need to consider as well, such as how do you even convert an operating room into an ICU room? What equipment do you need to take out of the OR to make that happen? What do you need to put in there? Are there enough ICU beds for the OR? Can you just even put the ICU patient on the OR table, or would you need a dedicated ICU bed for that patient? Do you have enough ICU beds for PACU and all your other satellite locations? Are there enough negative pressure rooms or isolation rooms to house all these patients? If not, could you cohort them in the area and then maybe install HEPA filters to at least filter out some of the aerosolized particles? What type of monitoring equipment are you going to use? Will the monitoring equipment in the ORs be able to communicate with critical care flow sheets? Will there be a central command area for you to be able to quickly monitor the patient's vital signs? Can there be a centralized location for the storage of equipment and donning and doffing taking place at a centralized location so that we don't spread contamination everywhere else? Also, we need to think about cross-training each other's staff on our ventilators so that in a dire situation and emergency, we know how to respond. And lastly, we'll have to know what the manufacturer's recommendation is on using these anesthesia machines as ICU ventilators so we can take the best care of our patients possible. Next slide. And that concludes the presentation when we reach the question and answer portion.
So, Jack, if you have a second, can you talk a little bit about how we're implementing some of this at Penn, including Penn Alert? I think you may be on the phone.
I know the relationships and all that stuff's important and understanding the patients, but it was just something I was conceiving. Like, does it make sense to have 3 attendings in that space?
I think Jack's on the phone. So, Gordon, can we? I know you guys have some experience up in North Philly. Can you talk about your experience a little bit?
Sorry, I was just getting a chuckle out of Jack. Can you repeat the question now?
I was kind of the real world implementation of some of this surge planning that we were discussing. It looks like Jack's off the phone, so I'll throw it back to him. But how are you guys starting to implement this up?
Sure.
Up north.
Yeah. So the planning for this began about a week and a half ago under our CMO's office. They sort of are the ones that mapped out the manpower and the geography of how we were going to respond. We've taken one of our hospital buildings, the Boyer building, which used to hold an operating room suite, a couple of ICUs, and a couple of floors of office space, as well as a couple of floors of patient space. we've converted that entirely to a COVID building. It has a dedicated CT scanner, so that's convenient. And all of our patients who are COVID positive are transferred there immediately. We have, I think, 2 floors of ICU care now being run by our pulmonary critical care service. We have 3 or 4 floors now full of either COVID positive or COVID rule out patients that are being staffed by other physicians, primarily our hospitalist service, and they're now splitting it with our anesthesiology service. We've taken 2 of the teams, they've taken 2 of the teams, and we've now brought in 2 more teams based on other subspecialists. So I'm working along beside ID docs and nephrologists who are rounding on these patients. And we're currently cross-training our CRNAs to work on the floors with a lot of the tasks that our nurses and our RTs are just overburdened and can't get around to. So they're doing phlebotomy, they're doing respiratory therapy treatments, and they've been cross-training the respiratory therapists on our anesthesia machine ventilators, so the respiratory therapists understand our machines, and they've been cross-training on the ICU vents so they can help out, just because we're anticipating we'll get to the point where our respiratory therapists can't staff all of their needs. So that's a quick outline. I'll throw it to Jack.
Okay, Jack. Welcome. Thanks for joining us. The question was just kind of like on the ground. We gave kind of a broad overview of what kind of generic surge planning would look like. Just kind of giving examples of how this is working on the ground at different institutions. Gordon just told us about his. Can you give us kind of a brief overview of what the surge planning looks like at Penn, specifically how you guys are integrating eLert?
Yeah, so there's, as you know, we have 6 hospitals. Only 3 of them are covered by telemedicine right now. We're trying to spin up the 4th and 5th hospital being covered, but more without the hardware that you drill into the walls type of support. So more iPads, FaceTime, deploying a bunch of iPads on stands that you could use in real time to FaceTime with an intensivist. Our telemedicine coverage in the past was just at night, and we're getting a second attending that will staff during the day. These will be people that are, for many reasons, cannot work in a setting with the COVID patient. So we're hoping to utilize them in that respect. And we may actually, as this progresses, put a second attending in day and night. On these sites where we have, much like Chester County or Princeton, where we have anesthesiologists entering the kind of the ICU world, that they're a little bit uncomfortable with, and sometimes we can give them a layer of support with that telemedicine to hopefully help this be a smooth transition over the coming months.
Thanks. So I'm going to start going through some of the questions we got through the registration. If you have any questions, please use the Q&A tab. Happy to get through as many as we can. First one I have is about medication and treatment paradigms. I know there's been a lot of talk both locally and nationally about different medication paradigms. What's being used, what's being actually trialed. I'll throw that to Jack and Gord, because you guys seem to have the most experience caring for these patients on the panel right now. Jack, are we doing anything specific as far as therapies?
We're using a lot of Plaquenil. And we do that for a 5-day trial. It's kind of hard for me to tell, whether it's doing anything. It's not noticeable to me. And then we are using remdesivir as we are able to get it. It's not easy to get a hold of, and there's pretty significant restrictions on its use. They won't give it to you if the patient's on pressors or in renal failure. So, and a fair amount of the patients that come in that I am getting to are in the beginning at least on pressors. A lot of the patients I get are, have failed nasal cannula and are getting intubated. And we have 3 people in ECMO right now.
Gord?
Yeah, so we have our pulmonology group has been very aggressive about recruiting trials. So most of the patients that are admitted and are ruling in COVID positive are on one trial or another. Generally, the escalation, the ladder of therapy has been hydroxychloroquine for anybody who's either stage 0 or stage 1, which means that you're either completely asymptomatic or you just have mild symptoms but don't really need any oxygen support. Most of those patients are going home. Once you're in hospital and you're on oxygen and you've got imaging proven disease, their first line therapy is ceftriaxone and azithromycin. The ceftriaxone is for bacterial superinfection. The azithromycin, the chief of our pulmonology department really feels that actually it's not being, its main function isn't really as an antibacterial in this particular instance, but has some effects blocking the inflammatory cascade, which seems to be the final pathway for severe disease. And then once patients are on significant oxygen or have a lot of disease burden on their scans, they're starting them on solumedrol, 0.5 milligram per kilogram for 5 days. And then they're, depending on the trial that they're enrolled in, there are antivirals and some immune globulins that they're using, but those are all research related.
Thanks. Next question is actually about using anesthesia machines as ICU ventilators. I know we talked about it in the presentation a little bit, but there does seem to still be some apprehension about using ICU ventilators, or sorry, using anesthesia ventilators or as ICU ventilators. I guess the question asks about clarification on the issue. I know APSF just put out a really nice, or APSF and ASA just put out a really nice bulletin on how that would go about, how we go about doing that. Again, Jack and Gord, if you would, where are the anesthesia machines fitting into your protocols going forward? Let's start with Jack.
So we've built, the phases as I saw you describe of our surging, and so there is a point where those patients will surge into the OR in the PACU space, and that's when we will utilize our anesthesia ventilators. And it makes sense because the surge will continue after that. We have ventilators kind of budgeted for that, but the people who will be taking care of those patients in that space will be the anesthesia residents, the CRNAs, PACU nurses, and the anesthesia attendings. So they're familiar with these ventilators. The FDA has just released some clearance to utilize them, because they're weren't really approved for long-term use before, but in this situation they can be. And we would use them with the same filter setup, CO2 clearance, et cetera. Right now, I'm not planning on using the inhaled anesthetic piece of that, but there's massive shortages right now of the sedative medicines. I just spoke with a New Jersey anesthesia chief who said they have a 7-day supply of propofol and they can't get more. We're running out of midazolam, we're running out of other drugs, so there is a potential that we may need to use inhaled anesthetics for some sedation there. I'll pass it on to Gordon.
Gord?
Yeah, sorry, I had to figure out how to unmute.
Yeah, sure.
I was trying to find a file and I lost my Zoom controls. Yeah, so I mean, with regard to the anesthetic machines, we did a tally of all the ventilators we could access within the healthcare system, and I think we came up with a total of 150 to give everybody a sense. I think roughly, I can't find the numbers, I couldn't find the file right this second, but roughly 70 of those are sort of traditional ICU ventilators that are utilized on a regular basis within the building, and then another 36 were our anesthesia ventilators that are immediately available. So that brings us to 107. And to give everybody a sense, those were ahead of some of the emergency and disaster use only ventilators that we had. So the plan is to use our anesthesia ventilators ahead of those other ones because they're really not designed for prolonged use. These patients are intubated for 3 weeks, 4 weeks at a time. And under those circumstances, these ventilators would be pretty questionable. I think just as a practical matter, I know that the question was asked, should we be promoting this or allowing this? I think under most settings, the institutions own the anesthesia ventilators, so the anesthesia department can rest assured it's not really your decision in the end anyways. If the institution decides to use the anesthesia ventilators because they need to, that's their decision. And in a sense, the liability is on them, but really at the end of the day, they're the ones that are going to derive that. I think your responsibility really is limited to providing your expertise into how best use them under those circumstances. And you probably have some obligation to become reasonably well informed. There are a number of manufacturers that are now putting out their recommendations. I think we went over some of those in the slides at the beginning about how you could use these under dire circumstances in long-term situations. So as the people most familiar with the equipment, you should familiarize yourself with those recommendations so that you can step in and provide your expertise when needed. But at the end of the day, the decision is not really going to rest in our hands anyways.
All right, thanks. Next question I had was about antibody testing. Do we know when we're going to be ramping up antibody testing? And if we know who's now immune, will they be able to help out those in need? I can tell you that there are institutions that are starting to ramp up antibody titer testing this week. I know ours is one of them. Ultimately, though, the question becomes what do we really know about immunity when it comes to antibody titers, because there's really there's no data on COVID and whether we have what levels of titer you need to have some degree of immunity. We do know there's a reinfection rate from the Chinese data. It's unclear whether some of that was reinfection or recrudescence, incomplete clearance. So there's a lot of there's still a lot of questions about the second part of that question of, just because we know what the titer is, what to really make of those numbers. And I think, I don't know if or when we're going to have a good answer for that. Any other feedback from the panel on that one?
I know the CDC has actually put out a guideline about, or a recommendation rather, of what to do if you're completely out of PPE. And their recommendation is to actually use healthcare staff who have recovered from COVID to then take care of COVID positive patients because of the potential of having some immunity. Again, I would caution against that because like you said, Rich, the reinfection rate is really unknown. There's been a lot of data coming out of China, also coming out of Taiwan, that shows that people who tested negative for COVID-19 can eventually be tested positive again. So we just don't have enough data to support that at this point.
All right. Next question I have is on MAC versus general anesthesia. The question is, I've heard that MAC procedures produce much less aerosol than general endotracheal anesthesia. If this is true, why are we intubating all suspected patients and risking ourselves using up valuable PPE? Mike, do you want to talk about that one?
Sure. So the whole theory about intubating these patients is when you're intubating and extubating a patient, you're doing it's potentially an aerosolizing procedure. And doing them under general endotracheal anesthesia, you're having two aerosolizing events. When you're performing a MAC on the patient, especially if the patient's in a deep MAC, they could potentially have airway obstruction. They could potentially start coughing. You may need to start mass ventilating them. Each one of these would be in itself a potentially aerosolizing event. So the whole point of converting them or starting with general anesthesia at the very beginning is to try to limit the amount of aerosolizing events.
Great. Anything else on that?
Sure. This is Joe Galassi. I'm going to throw out the question of for the panel. Does that mean you're not doing any MAC anesthetics anymore?
We are not doing any MAC anesthetics on any COVID positive patients or persons under investigation. That does not necessarily mean that we're not doing any MAC anesthetic, for example, for endoscopies or colonoscopies. We are still doing those. However, we are putting a mask on the patient while we're doing that. And everybody in the room has face mask, goggles, gown on.
I can tell you that by and large, we are not doing true sedation cases, let's put it that way. Most of our folks that are doing EGDs, because we've stopped doing outpatient EGDs for the most part, doing just inpatients, those patients are getting intubated for their EGDs. The volume has fallen through the floor on those in general, so it's not very many at baseline. The only patients getting the only patients who aren't going to sleep as a general rule are the ones who are being done under pure regional, primarily at this point C-sections and some orthopedic procedures that can be done under pure regional.
Yeah, and just to give you the full spectrum of options, so at Temple, we've decided that anesthetic technique is probably most dictated by clinical circumstances, and barring any evidence that one is better than the other, we've decided to just go with whatever the clinicians feel is most appropriate. We try and lean towards regional anesthesia possibility given the procedure planned. And then, you know, the most important aspect of this is anytime you're providing direct patient care to these patients, you need to have full droplet and contact precautions. So that's irregardless of anesthetic technique.
I can share with you that I agree with all the comments I've heard so far. I mean, I can tell you from my personal feeling is that if there is no risk factors for COVID in the patient and they're, for example, doing EGD, because I had a couple of outpatients that came in that somehow managed to pass our screening protocols, that they came in for EGDs yesterday. Both of those were done as MACs. And I spoke with 4 of our gastroenterologists who were working yesterday, and their feeling tends to be that the coughing tends to be more pronounced with extubation, because the day before my partner was working with them and he insisted that they all needed to be intubated, whether they were COVID suspect positive or not. And again, their feeling is that perhaps the irritation from the endotracheal tube being pulled is more likely going to generate aerosol than the coughing that may or may not occur during a non-intubated case.
All right, thanks. Next question I have is actually on malpractice insurance. Are there provisions being added to malpractice insurance to protect providers practicing outside of their usual scope of practice, and also protection from negligence claims if adequate medical care isn't available due to the pandemic? I know Mike and I had talked about this earlier, so I'm going to throw to him.
So you really have to take a look at your malpractice clauses. Most malpractice insurance will have a disaster clause in there that will cover you during periods of crisis and disaster such as this one, so that you can provide care outside your usual scope of practice, and that will be covered under the disaster clause.
I know some institutions also are granting emergency privileges for certain levels of ICU care. That may or may not be part of your institution's plan, depending on your policy. So I really suggest you reach out, take a good look at your policy, reach out to your insurer and your institution, and go from there. Next question I have is from do my friends in Philadelphia have an idea of the percentage of COVID positive patients or suspected positive patients that are requiring surgery, and what types of surgery? Gord, are you seeing a lot of COVID positive surgery up in North Philly?
No, I will say that Of the little or nothing that's related to the COVID disease, we've had a handful of patients who are COVID positive and who have had, needed to have an IND of an abscess or had kidney stones and obstructive symptoms and needed to have them stented or things like that. But they're more coincidentally COVID positive. They're nothing related. The COVID patient population themselves are a medical population and don't seem at this point to be developing surgical diseases.
This is Josh Atkins. I know one East Pennsylvania hospital actually did a COVID ectopic, and we actually simulated to test our processes for COVID patients in the OR. We used the ectopic example as one potential element.
In Allentown, we've had a few patients that were either positive or rule outs. One was a subdural. One patient had appendicitis, and after a long, drawn-out process, thought about it, they decided that they were just going to treat it medically rather than operate. We had another patient who was also a rule-out, who was an end-stage renal disease patient who they wanted to pull the PD catheter out, and they ended up going ahead and doing that case. So we have some things, obviously unrelated to the COVID disease that are being done, but we have 2 operating rooms that we've had set up that are going to be just for those COVID or COVID suspect patients that we've done, and we've pulled all the non-essential equipment out of there and have a runner outside the room if more equipment is necessary. One of which is our ECMO room, and the other one is for everything else.
I can tell you our very first true activation of our COVID response room was a rule out for C-section, and based on experience from some of my colleagues that I've talked to in New York, that seems to be relatively common. Again, true and unrelated to the underlying COVID diagnosis, just one of the more common surgical procedures out there. They're seeing a reasonable number of PUI and COVID positive C-sections. Anybody else? All right, next question here I have is, we do not have very many negative pressure rooms. How else can we protect ourselves in neutral pressure or even positive pressure rooms?
I think installing HEPA filters would be a good idea. If you can look into installing HEPA filters in the rooms and also on the floor where these patients are cohorted. I would talk to clinical engineering, see if they're able to convert some of these rooms into negative pressure rooms. Also, you got to remember when you do a COVID patient in the OR, how long do you need to keep the OR empty before you put another patient in there? What type of cleaning procedures do you have to do? Majority of places are recommending at least 12 air cycles between when the last COVID patient exits and the next patient goes in. So you have to take a look at what your airflow is in some of the rooms as well to decide when to put the next patient in there. But I would recommend at least taking a look to see if you can get any HEPA filters in there.
Rich, I'll throw in a comment here just for those people who work in areas where the resources are more scant, to give you some peace of mind. Currently, the CDC is really the only authority worldwide that's recommending airborne precautions. There's very little evidence to suggest that this is truly an airborne disease or an aerosolized disease outside of doing unprotected bronchoscopies on patients. Most of our patients at Temple are not in negative pressure rooms. So if you're dealing with these patients, if you're caring for them on the wards, contact precautions, drop-up precautions are the word of the day. You have to have your PPE on, your mask, your gown, your gloves when you go into the room, and make sure that you can take it off without contaminating yourself when you come out of the room. But don't stress about airborne precautions, because that's simply a standard that's not going to apply as the situation progresses.
Great.
I can
Go ahead. Go ahead.
chime in real quick. I know we were talking about the tiered process of ICUs. Our facility has got a plan in place that if they do need to use ORs as ICU beds, they are, the ORs are positive pressure. They have a plan in place to convert them to negative pressure rooms, and they'll take sections of the OR at a time as need be to do so.
Great. Thank you. Next question I have is about double lumen tubes and one lung ventilation. Since we have one side of the tubes open to the atmosphere, does that count as an aerosolizing procedure? In which case, should the surgeon, scrub tech also be wearing full PPE? Anyone on the panel doing double lumen tubes? I know at our institution, it's kind of been a slow progressive walk on these procedures. First, they were leaving the down lung open to the atmosphere. Then they were leaving it open briefly and then clamping it. And now they're actually just leaving the down lung clamped and letting it kind of collapse on its own without venting into the room. It's I think it's still a relatively open question. I know our ENT rooms, they're using full PPE for just about everyone. I think and our thoracic rooms for like mediastinoscopy and things like that, they're using full PPE. So they are definitely treating them as slightly higher risk. Anybody else have any comment?
I'm wondering, and this is just off the top of my head. I don't have a good answer for this, but I'm wondering if it would be useful in that situation to actually pass a suction, inline suction catheter into the non-ventilated lung, and then actually actively deflate the lung that way directly into suction. Maybe something to take a look at.
All right. There's another question. The next question that just popped up, once a patient is intubated, do we need airborne precautions for transport from, say, an ICU to the OR or ED or OR in the situation of a stroke?
No.
Yeah, I would agree with that. No. Our standard is once a patient is intubated, they refer to droplet and contact precautions. The one corollary I would urge everybody to be aware of is if you're transporting these patients around the hospital, and this is something you may need to make your respiratory therapist and your ICU nurses aware of, they need to have a filter between the endotracheal tube and the ambu bag so that they're not venting respiratory secretions all over the hospital as they're rolling down the hallway. So there always needs to be a filter attached to the endotracheal tube, but once they're intubated, it reverts to standard droplet and contact precautions.
So the other question that just popped up from the same questioner is what about if we need to suction? We are recommending inline suction on all these on these patients to try to keep everything within the closed system as much as possible. Gord, I just saw you pop off.
Oh yeah, can you see when I'm mute?
Yeah.
All right. Yeah, our intubation protocol actually includes, we have a filter with an inline suction attached to it. So as soon as we intubate these patients, before we, take the first couple of breaths to make sure that they're in the right position, we actually hook up the inline suction. The filter, and then we hook up the ambu bag. And what the instruction we've given to the ICU nurses is you should essentially never remove the filter, and inline suction should never be removed unless you actually, for some reason, need to replace the entire mechanism because it's clogged or getting dirty, and then that needs to be done under fairly controlled conditions. But our intent is to keep suction, everything attached to the patient's airway behind a filter once they're intubated.
Great. Couple of questions just popping up here at the end. Next question was about the new Abbott rapid test and whether anybody has it yet. I don't know if anybody has it yet. I think it was just approved.
Just approved. I think they were going to be putting out 50,000 test kits starting next week, I believe. It's supposed to give you an answer, a positive test supposed to come back in 5 minutes, negative test 15. But everybody's anxious to use it. It could be a game changer if people get it. That way you can allocate PPE to those that are actually taking care of patients who are truly confirmed COVID positive, and don't have to worry about suspecting everybody's an asymptomatic carrier.
Yeah, so I think I think one of the biggest hurdles so far, one of the biggest hurdles so far has been a lack of testing. So anything that speeds up the testing process and gets us an answer sooner rather than later will inevitably help us guide care. Next question. Let's see. Next question is, should we be adding anything to the consent process or pre-op documentation for non-emergent cases that we're doing? How are, I think a broader question is, how are panelists, are we seeing a significant reduction in non-urgent, in the non-urgent cases? I won't say elective. I know we have at Penn seen a significant recommendation or significant reduction. I am obviously discussing the elephant in the room when I talk to my patients, but nothing, no specific comments in the consent process as far as my practice is concerned. Gord?
Yeah, no, I mean, your consent relates to the risks of your anesthetic, and I don't think the inherent risks of our anesthetic really have changed at all, given the current circumstances. You might ask them, what are you doing out of your house? Why aren't you home? I certainly wouldn't be venturing out to have any surgery that I could reasonably put off for 3 months at this point, but people should be well aware of those risks inherently just because of their day-to-day lives, and I don't think that pertains to the anesthetic consent.
Next question about intubated patients and transportation again. Can't intubated patients who are not adequately sedated cough and exceed the cuff seal aerosolizing secretions? I think it is important that if you have these patients that are intubated, I think even if you're doing OR intubations at this point, that never have I been more sure to wait for my muscle relaxant to kick in and to make sure I had adequate sedation on board than I have been in the past week or so. And I think it's extremely important because I do actually, I do think it could be a concern if you are coughing and exceeding the cuff seal and aerosolizing in that way. I see Gord again, go ahead.
Yeah, everybody's looking for those Twitch monitors now, aren't they? I think that's important. That's key. You know, make sure that they're paralyzed before you intubate.
Quickly here, for epidural and spinal labor and C-section patients that are not known as a risk to be COVID positive, is it still recommended to use full PPE with an N95 mask? The current SOAP and SMFM guidance is that you really only need full PPE for persons under investigation and known COVID positive patients going to the operating room, mostly because the time you would have to don an N95 or other airborne precaution PPEs, you just won't have it when you're dealing with a devolving situation and somebody who's either failing regional anesthesia or needs to go to sleep during a C-section. Otherwise, putting in a labor epidural or putting in a spinal is a non-aerosolizing procedure. So, contact and droplet precautions are should be sufficient. And by and large, that's how most institutions are handling it right now.
Yeah, we're just on enhanced droplet precautions right now.
All right, next question. Are you guys finding that you have enough space in PACU or other non-OR locations for the anesthesia machine footprint? I think this was the question I think this was a question going back to surge planning and where we were going to put these extra machines if we needed to. So Jack and Gord, Mike, go ahead. Mike?
So at our institution, our plan really is to, as much as possible, try to keep the anesthesia machines in the ORs. We have about, including anesthesia machines, we have about 85 ventilators. So not a lot. And our goal is to try to keep them in the ORs as much as possible and use the ICU ventilators, some of the non-invasive ventilators that can work via an endotracheal tube, and use those as much as possible in the PACU and pre-op holding area setting. We do have a few anesthesia machines that do have a smaller footprint that can travel. So if it comes to that situation where they need to be on an anesthesia machine, we're preferentially going to use the smaller machines that can travel and use them in the PACU and the pre-op holding areas. But once they get to the OR, then that's the majority of where our anesthesia machines will still be kept.
Great. Next question I have is actually a pretty common one that I've seen, and I've seen several answers. If a patient needed to go to the OR, would you, given a positive pressure operating room or a neutral pressure patient room, would you intubate in a negative pressure room with airborne precautions on and then transport to the OR with gown N95 face shield booties? I think the transport we discussed, that once the patient is intubated and protected by the protected by a HEPA filter in line, that you don't need airborne precautions so long as they're adequately sedated and not going to be coughing around the cuff. But I think the big part of that question is, do you intubate a patient in the ICU room, the negative pressure room, or do you intubate them in the operating room? Given you have that decision, you have the ability to make that decision, and the patient isn't making it for you.
I think you would, in this case, it would be known COVID or POI. I would intubate in the negative pressure room. The whole concept of the negative pressure room versus the OR is you're not contaminating the space outside of that room when it's negative pressure. Most ORs are positive pressure. I know some institutions like ours are looking at converting a certain number of them to negative pressure, which I'm sure was already previously mentioned. But if the OR is negative pressure, you could do it there as well. But I think the ICU is a good location to sedate them on the way.
Gord?
I can tell you that our protocol at Temple is not to do that. We simply transport the patients with surgical mask. We ask the patient to wear a surgical mask, a barrier mask, transport them to the operating room, and then provide standard anesthetic care in the operating room. my read of the SARS literature is that there's just not compelling evidence that intubating under controlled circumstances is an aerosolizing event. So I think we're bending over backwards to achieve an ends that I'm not sure are valid.
Next question up here is if I'm wearing a PAPR, is video laryngoscopy still recommended as the first choice? Will we run out of supplies as we are with other products? Anybody want to jump on that one?
So our institution faced almost exactly that same situation when we first started, intubating everybody in the OR. We basically just intubated everybody using video laryngoscopy, and pretty soon we started running out of GlideScope blades very quickly. And it took a while for us to try to get them back in stock. So we basically said that all intubations will be done using PPE and a PAPR, and through direct laryngoscopy instead. And if you have, nobody should be within 10 feet of the airway during the intubation, except for the intubation team. So we want to have as few staff and personnel in the room as possible during those procedures. But yeah, if you have a PAPR on and you are short supply on GlideScope and video laryngoscopes, then yes, it's fine to intubate using a regular DL.
Jack.
I don't know. I don't do anesthesia anymore. I'm kidding, but I think it would be reasonable. I mean, some of the guidance from even that I've seen in EMS cases is it's safe to use the LMA as well to kind of protect aerosolization. I do want to go back to Gordon's comment on the intubation and aerosolization. There is a lot of people out there that would argue with you.
I know.
You're not in the majority. And it's not that I think you're wrong. I think people don't know about this, and it's such a scary time right now. People are being a little bit overly cautious. I think part of this is based on, we are trying very hard to put patients on COVID units. So take the healthy patients away from the areas where we have the COVID patients as much as possible, unless they're negative pressure rooms. And this is based on an assumption that somehow this is spreading from the COVID positive patients to the other patients. And what I really think is going on, they're just getting infected from maybe people taking care of them or other visitors. The same goes with the intubation. Anesthesiologists and respiratory therapists in China and in Italy seem to be getting a higher rate of COVID infection from the patients they're taking care of. Is this because they're intubating the patients? Is it because they're around during other types of aerosolization risk procedures like popping off a ventilator? Is it, from BiPAP? I don't think anybody can really quantify that. And there's been attempts to measure the rate of aerosolization with certain things like high flow, nasal cannula, and certain things like that. But they're never done. It's never done under the setting of a, SARS positive patient who's coughing like crazy. It's always a, kind of a normal patient who has a very well fitted mask or high flow. So I think there is some information we don't know. I suspect Gordon's probably right, but definitely there's a lot of other people who would argue again with that.
Yeah, to agree with Jack for a minute. Yeah, there's a whole lot of people who would argue with me on this point. I totally agree. But I think if you go back, the best evidence I think we have is the SARS outbreak in the early 2000s. If you go back and look at the epidemiological data from that time, it's reasonably compelling that appropriate use of just standard PPE, surgical masks, gloves, gowns, and eye protection stopped transmission of this disease in those patients. And that was a coronavirus, very similar to this. And there was very little evidence that it was ever transmitted in an aerosolized fashion. So I just worry at times that we are, as physicians, I think we have a baseline assumption that doing more is always better than doing less. And some of the infection control officers at Temple, who are very experienced and work in other areas overseas where they deal with truly deadly viruses on a regular basis. These are people whose lives depend on knowing how to do this stuff. They say the simplest answer is the best. The more complicated your PPE gets, the more difficult it is to use it appropriately and not contaminate yourself. And 9 times out of 10, if you get a disease while you're using PPE, it's because you contaminated yourself, not because you weren't using it appropriately. So I just think we need to just slow down a little bit and question some of the things that everybody runs for the PAPRs, but this person that I'm thinking of in particular at Temple, she says, it's hard to get a PAPR on and off without contaminating yourself. And it often takes 2 people, and it takes a prolonged period of time. It's not just a question of grabbing it and throwing it over your head and then whipping it off again when you're done. So I caution everybody to slow down, take a deep breath, and realize doing more may not actually make you safer.
Yeah, our ID docs have seconded that. They said, when you look at practical studies that have looked at true aerosolizing things like TB or non-aerosolizing like influenza, N95 has the same rate of infection of the person wearing the mask as a surgical mask. So, all these efforts to wear these high-tech, high filter devices, and when implemented in a practical fashion, may not be any better.
With that, I actually have kind of dovetailing nicely into that. I had 2 people ask me about N95 reuse and cleaning. Are there I can almost see the smile on Gordon's face. Are your institutions reusing N95s? Are you cleaning them? If so, how? I know we are being asked to reuse N95s for non-COVID patients. Kind of as a general rule, we're being asked to wear N95s for all intubations at this point, intubations and extubations at this point. We are working on implementing a cleaning process with trying to implement a UV in our institution, and one of our hospitals is already starting to implement it. Any other protocols from the other panelists?
Yeah, I know that there are UV-based protocols. I know that there are heat-based protocols that have been proposed. I think somebody also suggested radiation of some sort. I suspect that's, if we come to that, I suspect that it would only ever be effective if it were done on a mass basis. So in other words, you use an N95, you drop it in a barrel, your institution takes all the N95s away and processes them in a manner that is effective and they know sterilizes the masks and then brings them back for reuse again. I would really caution people against doing this on an individual basis. My concern is, again, the epidemiology suggests that if you get this disease, 90% likelihood is you touched a contaminated surface that was contaminated by respiratory droplets from an infected patient, and then somehow you got that infected surface, you put those virus particles in your mouth through your hands or onto your face or whatever. So my concern is if you take an N95 into a contaminated environment, somehow you get particles on the outside of it and you come out and then you keep that with you and you sterilize, either you don't sterilize it or you sterilize it in an inadequate fashion, and then you go back into another environment and put that contaminated mask back on your face. That may be the worst possible solution. So my honest answer is, if I were given the option of using the same N95 over and over again to intubate several different patients and having to take it off my face each time, or just take a new surgical mask each time, my own, and I intubate these patients. I've been intubating these people at Temple. If I were given that option, I would take the surgical mask.
All right, I know we still have questions, but unfortunately we have to bring this to a close. I want to thank the panelists for coming on, taking time. I know everybody who jumped on the line, both attendees and panelists. We're all super busy right now, so I want to thank everybody for coming on. And this seems to still be popular. So we'll work on when the next one will be. Just keep an eye on your email. Thank you so much, everyone.
Talk to you later, guys.
Good night.